Okay, so good evening, everybody. We're going to just wait for a minute or so and see if anybody else shows up. And yeah, then we will get ahead with today's course. Today, we're going to be talking about stomach and colorectal surgery. And we are going to first talk just about stomach surgery, and then we move on to colorectal as well. Okay, so we've got everybody, I think, who needs to show up has shown up, and I think we're going to begin now. So good evening, everybody. So this is your second class today on stomach and colorectal surgery. I hope you guys can all hear me, and and I hope that the screen and the slide is visible to all of you. So today's topic is entirely on stomach and colorectal surgery. The way we'll be doing this is that we are going to first look through stomach surgery, and then we are going to go through colorectal surgery, but just the essentials, because I want to keep this as short as is possible, but as impactful as it is as possible for your exams. So with that said, just a small reminder that this is part of the surgery and essential review course. Last week we discussed HPV surgery. And this week, today we are going to just do stomach and colorectal, and then next week we'll do colorectal, breast, and thyroid. So let's get into what we're going to study today in terms of overview. The stomach surgery section is going to have some essential conditions. So gastric and duodenal ulcers, gastric outlet obstruction, gastric volvulus, and then we're going to look into complications, three of the most important ones, bleeding ulcers, perforated ulcers, gastric cancer. And of course, the essential surgical management, what the vagotomies are, what kinds of gastrectomies that are normally performed, and gastropexy and pyloroplasty itself, right? Now, we are not going to go into a lot of depth here. We are going to go through the essentials, but in a manner that I hope is going to make things clearer for you and hopefully aid you in a concrete manner for your exams. So let's begin with the stomach. Now, when we look at the overview of the stomach, there are just a few things that you need to know. The most essential stomach diseases are the ones that you see on the screen. So you have peptic ulcer disease, gastroptosis, gastric volvulus, and gastric surgical operations. So when you look at the stomach from the perspective of both a medical student or a junior doctor or a surgeon, you try to look at the three most important illnesses that are a result of are related to the stomach, and of course a few important general surgical operations, because you will be performing these operations in some capacity or the other, right? And the reason why I put all of this in one screen is because I want all of you to know and bring your attention to the lowest part of the screen, which is the gastric surgical operations. Now, gastric surgical operations, are basically of four types. We have resections, right? We have gastrectomies, we have gastropexy, and vagotomy. Now, for all of these conditions, when we reach a certain point where surgical intervention is necessary, you'll be doing any one of these or a combination of these, right? So the surgical management, when it relates to the stomach, is entirely related to these four procedures and a combination of them. And you will notice that gastric resection actually is built upon gastrectomy, and it is rarely performed on its own. It is combined sometimes with a vagotomy, and more often than not, we perform a vagotomy with a gastrectomy. Now, for some patients, of course, we have to do a gastropexy. Gastropexy is essentially the stapling or the fixation of the stomach to the abdominal wall. And we'll go through this in greater detail as we progress through today's lecture, but I just want you to keep in mind some of these conditions. Now, we are going to go through all of this in greater detail, but this image is just so that when you study from this presentation, you have a general idea of what you are talking about when it comes to the breadth of gastric surgery. Now, on the right-hand side of your screen, you will see this image here, which is the vagal nerve innervation of the stomach. And in this image, you can see that the vagal trunk, essentially the vagus nerve divides into an anterior and posterior trunk as it goes down the esophagus and passes via the diaphragmatic hiatus, right? And so when it passes past the diaphragm, it has two branches, essentially, the anterior branch and the posterior branch. And each of these is a trunk. And the reason why this is important is because parasympathetic innervation to the stomach is responsible for gastric secretion, right? And in a lot of peptic ulcer disease, and maybe sometimes in gastric volvulus as well, you may have to combine this, you may have to perform a vagotomy, which is a transection of the trunk or divisions of the vagus nerve. And when we go towards the relevant sections, we will understand as to when we perform the kind of vagotomy that we want. And it is done at different levels, essentially, right? So we can do a truncal vagotomy, which is right at the top. And sometimes we do a selective one in which we go down and we only transect maybe the anterior trunk. And sometimes we have something called a highly specific vagotomy, in which we only transect the crow's foot or the criminal nerve of Grassi or the Latargus nerve, which innervates the inferior curvature of the stomach. In terms of the gastric anatomy as well, it is also very good to understand the blood supply. And the reason why we try to understand the blood supply is because the complications of peptic ulcer disease and gastric cancer have a lot to do with being able to identify the blood supply. And when you look at surgical philosophy, which is, when you try to determine the kind of operation you are doing, in a lot of cases, we have to always, for any organ for any organ or any viscous or any surface that we are trying to operate, we have to know the blood supply to that location. And in this case, the most important one for gastric surgery is the gastroduodenal artery, because this is the most common site of bleeding in bleeding ulcers, right? And so also, I would like all of you to remember that the celiac artery or the celiac trunk provides a lot of the arterial supply to the stomach, both in a direct and an indirect way. So a direct way would be this right gastric artery is a direct branch of the celiac artery. It comes as an early branch of the common hepatic artery. And of course, the left gastric artery supplies the gastroesophageal junction here. And when you look at this splenic artery as well, the splenic artery eventually gives the main splenic artery, the short gastric arteries, and the left gastroepiploic artery. So just keep this in mind, and at the relevant operative sections as well, this image will be there to aid you in your revision of the operating procedure. So the first thing we're going to talk about is peptic ulcer disease. Now, peptic ulcer disease is essentially the formation of ulcers due to two factors. The first factor is that there's either an H. pylori infection, right, or there is acid hypersecretion. Now, when you look at the gastric mucosa, you need to understand that it has a protective function. So acid is being released into the stomach, and to protect against that acid, you have the barrier system of the mucosal barrier itself, and you have alkaline secretions as well, which sort of neutralize the effect of the acid. Now, when you have an H. pylori infection, what happens is that the H. pylori infection starts breaking the mucosa, and this break in the mucosa is what causes the ulcer, right? So when you look at the peptic ulcer itself, peptic ulcer generally refers to both gastric ulcer disease and duodenal ulcer disease because they present more or less the same way. Now, there are some ways of differentiating between a gastric ulcer and duodenal ulcer. And for that, you need to do an imaging study, which will go on in the next slide. But here, I would like all of you to just take a look at the most important thing about the classification itself. So how do we classify peptic ulcer disease? We classify peptic ulcer disease according to the modified Johnson's classification, in which we take into account the location and the acid secretion of the ulcer itself. So most of the time, you are looking at type 1, which is on the lesser curvature near the incisura angularis, but more closely towards the gastroesophageal junction. Type 2 is also on the lesser curvature, but below the incisura angularis, which is here, type 3. And type 2 is a type of ulcer in which you have one ulcer in the duodenum and one ulcer in the greater curvature, or anywhere along the greater curvature, right? And type 4 are any ulcers that are very close to the fundus, and by implication, very close to the gastroesophageal junction itself. Now, there is also another way of classifying ulcers, and ulcers can be classified according to their size and their malignant potential, right? So what happens is that you have benign ulcers and malignant ulcers, and benign ulcers, it's difficult to understand ulcers themselves without having a proper biopsy. So when we go up to the workup or diagnostics section, we'll think about and we'll discuss the appropriate imaging. But when you're writing your essay about peptic ulcer disease, there are two things from this slide that you need to mention. The first is the modified Johnson's classification, right? The cause, which is the H. pylori infection, more often than not, and the complications. Because complications here, intractability, hemorrhage, obstruction, and perforation, are also the indications for surgical management. So for example, if you have a patient who comes to you with peptic ulcer disease, the most important thing for you to understand is whether you can treat this conservatively or if you need to treat this in a surgical manner, right? So with that said, let's go on to the next slide here, where we look at how you're going to diagnose a patient with peptic ulcer disease. So in terms of the symptoms, the only difference between a gastric and a duodenal ulcer is the fact that there may be pain after eating. And so duodenal ulcers always come after eating, whereas epigastric or gastric ulcers come when the patient tries to eat anything, right? And the important thing for you to understand is not just the fact that this patient has a peptic ulcer, but also if this patient has a perforated ulcer, because perforations and bleeding are very common, and perforation is a little more dangerous than bleeding. And the reason for this is because there is a direct communication between the peritoneum and whatever is inside the stomach, right? So if you have a patient who comes to you with these three additional symptoms over the general symptoms of the gastric and duodenal ulcer, like such as peritonitis, guarding, and severe pain, then you should suspect that this patient has a perforated ulcer and then determine what you need to do next, right? So you have this thing called the upright chest abdominal X-ray, and you do this in patients in whom you think that there is a perforated ulcer. If a patient does not have peritonitis, if the patient is not guarding and is not in severe pain, right, then you just go on to the other diagnostics, which is esophagogastric duodenoscopy, right, which allows you to perform a hemostasis in bleeding patients, and you do a complete blood count. Now, the purpose of diagnostic tests is essentially just to see if there is anemia in the patient or not. You can do a test for confirming H. pylori, but when you have an ulcer, you can just assume that this patient is H. pylori positive, right? Now, in terms of imaging, you have three options. And now, the mainstay is to try to use esophagogastric duodenoscopy or just fundoscopy, and you just take a look at the entire esophagus and the stomach, and if you can see this ulcer, for example, this is not a very large ulcer, but this is an ulcer. You take this, and then you can do a biopsy of this ulcer mass, and you can try to attempt a hemostasis if there is active bleeding present, right? But if, for example, this patient comes to you with this perforated ulcer symptoms, peritonitis, guarding, and severe pain, then you need to do an upright chest and not do a barium swallow, because a barium swallow is the ingestion of contrast material. And in any case where you have a perforation or you suspect a perforation, you should not use barium at all, right? So you have two options, essentially two pathways when your patient comes to you with symptoms such as these. You need to do an imaging study anyways. So the best thing to do is you try to do an upper chest and abdominal, upright chest and abdominal X-ray to see if there is free air under the diaphragm. If there is free air under the diaphragm, then yes, you can immediately say that this patient has some kind of perforation, whether it's intestinal or whether it is intestinal perforation or it is a duodenal perforation or a gastric perforation remains to be seen. And for that reason, you can just open up the patient and see, look, then repair, right? Now, when you look at the therapeutics of peptic ulcer, 99% of the time, what we do is something called therapeutic management through triple therapy or quadruple therapy. Because what we are attempting to do in this case is most peptic ulcers nowadays can be dealt with just by using medication alone. Your job as a surgeon is to determine the cases where you need to operate, right? So you operate only when you have those indications. Intractability, which means that the ulcer is not healing despite therapy, or there is a hemorrhage, there's some kind of bleeding, so you need to stop the bleeding, or there is an obstruction, or there is perforation. If you have any one of these indications, then you operate. Otherwise, just keep it simple by managing it through therapeutics. Now, therapeutics, you have two options here. First is triple therapy, which is the classic medical treatment in which you use proton pump inhibitors like omeprazole to reduce the amount of acid present in the stomach. You use clarithromycin and amoxicillin to completely eradicate H. pylori. And proton pump inhibitors are very good because they serve two functions. One is that they reduce the amount of acid inside the stomach. And the second is they help to protect the gastric mucosa as well. Now, why should we choose quadruple therapy? Now, there is a difference here. In a lot of cases, we have something called clarithromycin resistance, which means that if the patient has taken clarithromycin in the last 3 years, you can suspect that there might be some clarithromycin resistance. So in that case, you ask the patient if they're taking clarithromycin for anything. Now, in Bulgaria, for example, clarithromycin is often prescribed for upper respiratory tract infections as well as some lower respiratory tract infections, right? So in that case, it is better to go for quadruple therapy. Now, quadruple therapy is based on bismuth, which acts as a surface protectant. It protects the gastric and duodenal surfaces from acid, and it helps to sort of protect the mucosa from further damage, right? So in that case, what you do is you combine bismuth with metronidazole and tetracycline, and you add a proton pump inhibitor, such as omeprazole. And you continue this therapy for 14 days for gastric ulcers, which are non-complicated, right? And in those patients in which you suspect that there is a duodenal ulcer instead of a gastric one, you do it for 4 weeks, right? Now, the main thing about bismuth that you should know is that bismuth is a very good protectant. It protects the gastric and duodenal mucosa, and it also acts as a very good healing agent. Because what we want to do is to try to promote the healing of the ulcer. And because the ulcer essentially is a break in the mucosa, right? And so as long as you can heal the ulcer and you have a complete healing, the patient is safe, right? Now, when do we now choose surgery? Now, we choose surgery when we think that this therapy is not working. So after 4 weeks, if you see that the ulcer is still there, the patient still has symptoms, there is still evidence of infection or bleeding, or or if there is some kind of perforation, then in that case, we move on to surgical management. Now, with surgical management, remember, again, we are going to go through the indications here: intractability, hemorrhage, bleeding, and obstruction and perforation. If you have any of these symptoms, if any of these are the characteristics of the ulcer that you see on the follow-up or upon initial presentation, then you need to do surgical management, right? Now, surgical management essentially consists of two different operations, right? One is the gastric resection itself, right, which you see in the center, and the second is the vagotomy. Now, if you look at this image here, and it is not very clear, and I apologize for that, but when you look at it in the presentation on a larger screen, you'll be able to understand it. We have 3 levels of vagotomy. Now, the purpose of the vagotomy, I'm going to repeat again, is to reduce the vagus innervation to the stomach so that you can reduce acid secretion, right? Because acid secretion is what is causing further damage once the mucosa has been eroded, right? And in this case, the vagotomy is always combined with gastric resection. You never do just a vagotomy alone. You have to do some kind of resection. And in terms of perforation itself, the perforation surgery is very different. Now, normally perforations are very small. Now, because they are small, all you have to do is you just take an omental patch and you sew it shut. Now, we'll be discussing this in greater detail just in the perforated ulcer disease section. But here, I want to draw your attention to gastric resection. Now, gastric resection consists of two operations themselves. One is an antrectomy, in which you are removing the antrum, which is this part of the stomach. And the second is you remove part of the duodenum, and then you connect the duodenum with the remaining part of the stomach. Okay. And in terms of gastric resection, we have three options. The first is Billroth 1, right? The second is Billroth 2, and the third is the Roux-en-Y. So Billroth 1 is when you just resect the antrum, you do a partial duodenectomy, which is the first part of the duodenum is removed. And then you bring up the second part of the duodenum and you attach it here through an end-to-end anastomosis, and you stitch this closed. Now, in most cases, what has happened is that you do Billroth 1 for type 3 and certain types of type 2 ulcers. So, for example, there is one duodenal ulcer, right? And maybe the other ulcer is somewhere down here, right, along the greater curvature. In that case, you do Billroth 1. And for all type 3s, you have to do a Billroth 1, right? Now, there is a lot of literature which says that for peptic ulcers, which are type 3 types, usually just using medical therapy is enough, right? Now, the issue with Billroth 1 is that we have something called gastric dumping syndrome, in which the stomach sort of balloons up with lots of food, and suddenly everything rushes straight into this efferent limb, or the limb that's going away, right? In order to prevent complications from Billroth 1, they developed something called Billroth 2. So in Billroth 2, what happens is that the major difference is that instead of connecting this through the side through something called a gastroduodenostomy, in which you connect the duodenum itself, you don't connect the duodenum, right? You connect the jejunum instead to the remaining part of the stomach, right? So it is called a gastrojejunostomy, which is something that is going to be asked in your exam, because the professors will ask you, what is the name of Billroth 1? What is the formal name for Billroth 2? And in this case, you basically do a gastric bypass, remove part of the duodenum, you take the second part of the duodenum and stitch it, close it shut, and create something called a blind pouch. And this jejunum is sort of cut open and connected on its side to the gastric, whatever is remaining in the gastrium, right? That is Billroth number 2. Then you have the Roux-en-Y. So in the Roux-en-Y, what happens is that you are essentially connecting the same jejunum, right? But you resect part of the duodenum and you reconnect it to the rest of the jejunum itself. So you have an end-to-side anastomosis here and one side-to-side anastomosis. Now, an important factor is that in patients who undergo Billroth 2, you may have to convert them to a Roux-en-Y because they're having some kinds of complications. The most common complication is when they have dumping syndrome, right? When all of the stomach content rapidly gets into the jejunum, right? Causing immense amounts of pain, something called reactive hyperglycemia, and then sudden hypoglycemia, right? And the second is because you don't have proper bowel continuity here, because you can see that the loop, there are too many loops here, and this can affect the peristaltic motion, allowing proper movement of the stomach contents, right? So in the second part, what you do is you revise the Billroth 2 to a Roux-en-Y, in which you can see that because of the angles and the connections, all of the food is going to come here, get digested, and go down the tract, where it is then connected to the duodenum. Now, the duodenum actually has the connection of the pancreatic duct as well, because you take the pancreatic duct and you reattach it to one of these limbs. Either you attach it to the remaining part of the duodenum, or you attach it to the side here or here, so that bile can still be passed into the bowel. Okay, so that is your section on gastric resection. And we have different types of indications as well. Sometimes we can do a total gastrectomy, in which you remove the entire part of the stomach and just do a Roux-en-Y, right? And this is also called a gastric bypass sometimes, because sometimes you can just connect this directly into the gastroesophageal juncture and let the remaining part of the stomach be inside the abdomen itself instead of taking it out, right? And the other thing is that you have subgastrectomy, which is what you see in this image here, because the entire stomach has not been removed. Okay. So we will now go into perforated gastric ulcer. Now, if you have any questions up until this point, please type them in the chat. I can see that there are 2 questions already, so I'm going to address them before we go any further. So There is a question here if gastric ulcer causes pain on an empty stomach. Yes, because gastric ulcers can cause pain just about any time. But duodenal ulcers usually cause pain after you have eaten, right? Now, gastric ulcers, the major issue with gastric ulcers is that they are going to cause intermittent amounts of pain. And the reason why they cause pain in general is because more acid is being released in anticipation of food, right? So gastrin, which is this hormone, acts on the antrum, on the chief cells, in addition to the vagal nerve stimulation, and more acid is produced, and this acid causes the greater amounts of pain. And this happens a lot in the empty stomach because when the stomach is empty, the patient is expecting food, and the signal for hunger also ends up becoming a signal for pain, right? Now, in duodenal ulcers, it is a little different because the pain from the hunger is relieved when you eat. Whereas in gastric ulcers, the more food there is going to be this positive feedback of excessive amounts of gastrin and extra HCl or acid production. And this causes a lot of pain when the patient eats as well. Whereas in the duodenal ulcer, because the duodenal ulcer is on the duodenum, it has very little to do with the gastric secretion itself. What happens is that all of this gets mixed up with the food. And then when the food enters into the duodenal tract, that's when you have a lot of pain. So in many cases, what the patient will do is that they eat normally, but 1 or 2 hours after eating, they suddenly start having pain. That's when the food is inside the duodenum, right? Because the acid content from the stomach mixed in with the food enters the duodenum where the ulcer is, and that ulcer is irritated by the food plus the acid, right? Now, there is another question here called the fasting serum about the questioner is asking about fasting serum gastrin test. Yeah, this is good, right? But fasting serum gastrin test is used for understanding whether the patient has gastrinoma or not. That is usually done when you have established that there's an ulcer or a mass, and now you want to know the characteristics of said mass. So it is a better biomarker for gastrinomas. So gastrinomas are a specific type of neuroendocrine tumor of the stomach, where in this area, essentially, if you look at your screens now, there is a gastric tumor somewhere here that is not caused by peptic ulcers. Its pathology is very different, right? And you do that when you've actually exhausted everything. You've ruled out there being an ulcer. You know that there is going to be some kind of mass, right? It comes with acid hypersecretion, but they may not be an ulcer. You understand? So that is the only difference. And we do a serum gastrin test mostly to understand whether this is a gastrinoma or some other kind of cancer. Now, the third question is, do we always go for Billroth 1? And only do we go to the others if the complications or location doesn't allow for Billroth 1? Look, Billroth 1 is usually done when the ulcer size is very large. So if I go back to the screen here, Billroth 1 is used for type 3 and certain types of type 2, where the gastric ulcer is somewhere along the greater curvature, and you can remove this whole thing. That's when it's called a Billroth 1, right? You do a Billroth 2 when the tumor is a typical type 2. So that means one ulcer is on the duodenum, and the second ulcer is on the greater curvature somewhere, and you can cut off this part of the stomach, right? We do a Roux-en-Y when the Billroth 2 generally either fails, or you have a type 1 that is so high on the angular, that's in closer proximity to the gastroesophageal junction. So for example, this is a type 1 in which you can get away with doing a subtotal gastrectomy and still do a Billroth 2 because you have enough space here or enough remaining stomach volume. If this tumor, for example, was very close to the gastroesophageal junction, then you would have to do a Roux-en-Y in which you remove this whole thing, leave only the fundus, and then you do this rearrangement, right? So we do Billroth 2 essentially based on the location, and Roux-en-Y based on complication, right? Billroth 1 is also used generally only for type 3s and certain types of type 2 where the gastric ulcer is closer and in closer proximity to the pylorus or in the antrum and can be resected en masse, right? So I hope that answers all of your questions. Okay, so now we're going to go into perforations. What would be the surgical treatment for type 4 ulcers? So for type 4 ulcers, we do a Roux-en-Y. So in type 4 ulcers, what happens is that, so this is a subtotal gastrectomy, right? But instead of doing a subtotal gastrectomy first, what you would do is a total gastrectomy. So you remove the entire stomach, and you will have only a bud left here. So it's just a little bit of the gastroesophageal junction, and then this is directly connected to the remaining jejunum, and all of this is moved towards the side. That is the type 4 ulcer treatment, because you will have to remove everything here, and there's a reason for it. The reason for it is that if it's a type 4 ulcer, it is right up there. The blood supply doesn't allow you to just cut a small bit off. All of this blood is being fed into by big arteries, and you need to remove all of them. Otherwise, you'll have constant bleeding again and again. And we have to try to stop all of that bleeding, right? See, in most operations, remember that the reason why we choose operations of a certain type is based on the location of the tumor. And now, this is a more important concept when we go to colon surgery. But in gastric ulcers or in anything else, the type of operative technique we choose has three major factors. The first is, where is the tumor located, or where the damage located, right? Second is, what are the expected complications, and whether those complications are acceptable to us or not. And the third is, I have to always ask myself, am I going to have to do this operation again? Whichever one of these options gives me the lowest amount of complications and recurrence, I will go with that. Now, because of various studies, Billroth 2 is done, right? Because it's more easily tolerated, but you may have a recurrence, not of the ulcer, but you may have a recurrence of high levels of complications. So in that case, you have to convert it to a Roux-en-Y. But we take Roux-en-Y as the first step if the location allows for it, right? So that's how we think. Now, in surgery, there is this idea of surgical philosophy, which tells you that you try to do the simplest technique with the lowest amount of recurrence or complications. That also gives the best outcome for the patient. So you are trying to balance three different things at the same time, essentially. So I hope that has answered everybody's questions. Okay, so now we're going to go into a perforated ulcer. So in a perforated ulcer, what happens is that the gastric mucosa has been damaged so much that there is a small hole in the stomach itself, right? So the symptoms are, there's a sudden onset of abdominal pain, severe tachycardia, and abdominal rigidity. So abdominal rigidity and abdominal guarding are both evidence of peritonitis. If there is peritonitis, that means that you need to open up and see what is going on, right? In this case, what happens is that the peritonitis is caused by chemical peritonitis because the stomach wall has been completely, there's a hole in the stomach wall. All of that acid is going into the peritoneum. And if it is going into the peritoneum, it is going to cause you peritonitis, right? And of course, once there's acid in the peritoneum, other organs can be damaged as well. So you need to open this up quickly, clean everything out, and put a patch, right? So in this thing, what we do is we do something called a Graham's patch. So Graham's patch is when we take a part of the omentum, right? We cut it off, and then we plug it after we suture the initial hole. So, for example, there's the main way that we treat perforations is we just close it shut on its own. You see the hole, we sew it shut. We put a second layer, and then on top of that, we put the omental patch, right? And this omental patch actually has to have its own blood supply because there's a lot of mesenteric veins and arteries flowing through this patch. So you just choose one area that has its own blood supply so that that area can be perfused well. And then you just tighten it and seal it shut, right? So if you think that a patient has a perforated ulcer because they have these symptoms, tachycardia, abdominal rigidity, symptoms of a peptic ulcer, and you have done a upright X-ray and you see some free gas under the diaphragm, you open up the patient and you see there is a perforated hole in the gastrium. The point is that before you do all that, if you ever suspect that this patient could have a perforation or a bleeding, you need to insert an NG tube and administer IV antibiotics and PPI, right? Because PPIs serve the function of actually protecting the gastric mucosa. So in this case, what you do is you can do a serum amylase test. And the only reason we use any kind of diagnostic test is to rule out other conditions, right? So, for example, I do a serum amylase and lipase test. It is just to rule out whether there is acute pancreatitis causing these symptoms or not, right? If the serum amylase and lipase is normal, which is the case with perforated ulcers, then I know that this is just a perforated peptic ulcer. I need to plan for a Graham patch. And what I would do is to just give aggressive amounts of fluids so that the patient does not go into shock, and give the patient IV antibiotics, give them a PPI, and insert a nasogastric tube. Now, the nasogastric tube does two things. First is it removes all the excessive acid before you operate. Second thing is that when you do this Graham's test, right? Like when you do a Graham's patch, you need to do a leak test to see whether the perforation is tightly closed or not, right? So if you want to know if the perforation has been tightly closed, you insert a blue dye through the NG tube, and you in the operative field, you should not see any of the blue dye coming out of the stomach. Because if it comes out through the stomach wall or from underneath your patch, that means you haven't secured it properly. You have to reopen and redo it one more time. Okay. So that is how you deal with a perforated peptic ulcer. Now, perforated peptic ulcer is important from your exam perspective for two things. One entire essay topic is dedicated to the perforated peptic ulcer, right? And in this case, in your essay, you need to mention all of these things that you see on this slide here. In particular, the use of the Graham patch, right? You have to at least know the word Graham patch, in which you put a piece of the omentum over the perforation after you've done primary closure. So primary closure is very important. You see a hole, you stitch it shut, then you put the omental patch on it, also called a Graham's patch, seal it, test whether it is patent or not, whether it's been stuck properly, and then you can confirm that it is done, and then you close the stomach, right? So this is the idea of the perforated ulcer. Now, a good clinical tip is, you can ask the patient based on their history as to what stage of the disease they are in, right? We have to try to prevent, like the basic idea is that patients will come to you with severe epigastric pain and tachycardia. Most of the time, realistically, are in the second phase. That means they already have abdominal rigidity. Their pain is worse on movement, and it is no longer a sharp epigastric pain. It's pain all throughout the abdomen because of peritonitis, right? So when patients are coming to you in stage 2 or the second phase of a perforated ulcer, you have to try to prevent circulatory system collapse, which is why you give the aggressive fluid resuscitation, right? And even in aggressive fluid resuscitation, remember that saline is always better than anything else. Give saline if you're not sure. If you don't have any other biochemical analysis, nothing, just give aggressive amounts of saline. That's it. You can choose Hartmann's and all that later. Your first line of resuscitation treatment should always aim towards increasing the amount of volume in the blood. You can correct the electrolytes in a more accurate way using Hartmann's later. First step, always try to use saline, right? So now that we've covered perforated peptic ulcer, I would like all of you to take a minute and try to think of any questions that you might have, or if there is something that you'd like me to repeat, right? If you have any questions, please type them in the chat and I'll get to them immediately. Okay, so I'm assuming there are no questions so far about perforated peptic ulcer. We are going to go to the next one, which is bleeding peptic ulcer, right? Now, in the bleeding peptic ulcer, what actually is happening is that the ulcer has begun to bleed, right? And the only way you would know that it is actually bleeding, right, is if you do a CBC and the CBC shows anemia, right? Or which is generally characterized by a low hemoglobin count, right? And if you do an endoscopic view. So if you do endoscopy, you can see that there is some bleeding in here. The next step would be that you try to classify the bleeding using Forrest classification, right? Now we'll come back to Forrest classification in just a second. But when you have bleeding, right, most patients, if they're bleeding throughout their stomach, they are going to tell you that they are either vomiting blood, right? They have melena, right, which is an evidence of slow amounts of bleeding, right? And they will have epigastric pain with a lot of weakness and anemia present. And the clinical definition of an anemia, like you suspect a patient is anemic, if they have very cool extremities or there's some amount of paleness and easy sweating, right? And they feel weak in the absence of other symptoms, right? But to confirm anemia, you need to do a complete blood count. And in the complete blood count, you will always see anemia as apparent, right? Now, you've seen this patient, you think that you are looking at the esophagogastric duodenoscopy or an endoscopy. And in the endoscopy, you see a certain amount of blood or whatever. You need to report it according to Forrest classification. Now, I have marked this as red simply because in your practical part of your exam, when you're actually seeing patients, you will always be asked about Forrest classification, right? So I would remind all of you to memorize forest classification, because if you don't know forest classification, you won't pass the practical part of the paper. Okay. So forest classification is divided into three types. The first is active bleeding, and active bleeding can be of two types: active spurting, right, or active oozing. Active spurting is essentially when the artery is bleeding. Active oozing is when there is venous bleeding, right? Then forest 2 is based on recent signs of hemorrhage. That means that you can see a visible vessel that is not actually bleeding. You can see an adherent clot, or you can see a hematin-covered lesion. And forest 3 is when there is no active bleeding, but you know that there has been bleeding in the past, and the entire area appears eroded. So in this image here, you would typically define this as forest 3, whereas this image on the left-hand side, that is forest 1B, because you can see the blood is still kind of flowing and oozing, right? So please remember the classification of bleeding, which is forest classification. Okay. Now, in terms of management, you have two options, right? So we give the patient tranexamic acid, which is a blood clotting agent and reduces hemorrhage, right? You give the patient PPIs, right? And you have to insert a nasogastric tube. Okay. Now, the purpose of the nasogastric tube is, again, to drain out any kind of acid that you see, drain out any kind of fluids, right? And also, in case if you ever need to make some kind of stitches or any kind of repair, is to check its patterns, right? So you have two options. You can do endoscopic control, right, where the bleeding is very, very small. It doesn't require to do much resection, right? Second, the patients have to be stable. So if this is a very elderly patient in her late 80s or something, or early 70s, right? In an elderly patient who's losing a lot of blood, severely anemic, very weak, in that case, endoscopic control is not going to do anything. You need to manually try to stop the bleeding and maybe do a gastric resection as well, because there might be ischemia, right? Second, you have two options for endoscopic control, right? So in endoscopic control, you can do cauterization. You take a monopole cauterizer, right? And then you just sort of cauterize the bleeding area. And you can just insert a lot of adrenaline in the area that is bleeding, causing vasoconstriction. So if vasoconstriction occurs and you're successful, okay, that's fine. You keep monitoring the patient, right? But if, for example, this is not working, you immediately move to surgical management. You don't wait. If you can't stop the bleeding endoscopically for whatever reason, you go into surgical management. Now, in surgical management, what is happening is that we attempt to do manual closure of the vessel itself. Now, the most common artery that bleeds, or the most common bleeder, is the gastroduodenal artery. Because of its very important position here, it is right over the pylorus and the antrum. That is the area of the highest amount of acid secretion. Like ulcers occur there, and those ulcers are more likely to bleed than others, right? Now, when I say the term or the phrase more likely to bleed, does not necessarily mean that other types of bleeding don't occur. They do, right? But most commonly, it's the gastroduodenal artery. What you do in this case is you have two or three different options. Number one is, if the area around it doesn't look ischemic, it doesn't look like there is some kind of necrosis, the ulcer size is not very large, right? And the bleeding spot is small, then you can just sew it shut. That's it. You squeeze, control the bleeding on the gastroduodenal ulcer, and then you just close the ulcer itself and just put a patch over it, right? That's it. But you need to still combine this with a vagotomy, right, and a pyloroplasty, because this ulcer is very close to the pylorus. The risk is that even if you try to repair it and fix it, what could happen is that this area will fibrose, because that's a response to injury, and that can cause a pyloric obstruction, and that's why you need to do a pyloroplasty. So in a pyloroplasty, you just remove the pylorus and reconnect the duodenum and the stomach, right? And in a pyloroplasty, you don't cut the whole pylorus. You make a cut only through one side of the bowel, and then you just fold it on itself, right? You do pyloroplasties usually for type 2 and type 3 ulcers, which are located in this pylorus antral region, and they are of large enough size that they could pose a risk for gastric obstruction either now or sometimes in the future, right? Now, in gastric resection like Billroth 1, Billroth 2, right, or a wedge resection, all of these are done generally for type 1, 4, and 5, which are, 1 and 4 are on the top here. Type 5 is a gastric ulcer that is caused entirely by NSAID use, right? This kind of resection is done usually when you think that this gastric tissue is completely damaged. So when you look at it under your hand, when you open it and see, you will see that this tissue is very easy to break, or it has patches of necrosis, patches of ischemia, or there is a lot of redness and erythema, and the ulcer surface is like sort of spreading. In that case, you do a wedge resection, which is basically cut a wedge out along the ulcer and then resect whatever is left, right? Which will end up becoming a Billroth 1, Billroth 2, whatever. Or you do a total gastrectomy in case of type 4 that are very, very close and are also bleeding. And for most of the types, you can go with a Billroth 2 mostly, or a Roux-en-Y. And in some cases, Billroth 2 is better than doing a Roux-en-Y. And the only cases where it is better is when you have in specific a type 1 or type 4 type ulcer, right? So we've completed the bleeding ulcer section, right? Do we have any questions so far? Like, take a minute, and we are going to go into this a little more deeply, which will also help to answer your other questions. But if you have any questions, I'm going to take a minute, and you can type your questions in the chat, and I'll get to it. Okay, so I'm assuming there are no questions so far. So I'm going to take a little bit of time to sort of localize the surgical management here. Now, type 1 ulcers, right? You can do two things. Billroth 1, Billroth 2 are a highly selective vagotomy. Now, in this image, you can see what a highly selective vagotomy means. In the highly selective vagotomy, all the anterior curvature of the stomach, that the vagus innervation to that area is being removed. You do this and you combine this with either a Billroth 1 or Billroth 2. Okay? And you do this so that you are going to reduce the amount of acid secretion in the patient by reducing the vagus nerve innervation, right? For type 2, you have some, you also do a vagotomy, but the vagotomy is usually done, the vagotomy is usually either a selective vagotomy, if the tumor is over here, or a total vagotomy in which you remove the entire trunk. So you can see this part here, which is the part of the anterior trunk, sort of coming down over the pyloric region. So this is usually for type 2s and type 3s. Type 2, because one ulcer is here. As you can see, one ulcer is on the duodenum. So that the tissue surrounding that should not have excessive amounts of acid. So we do a truncal vagotomy. And the other tumor could be, the other ulcer could be anywhere here. Now, type 3 is when this ulcer is very close to the incisura angularis, which is lower on the greater curvature. And in this case, also, you do a truncal vagotomy, and you do an antrectomy with mostly a Billroth 2 resection. In some cases, you can do a Billroth 1 if the tumor size is very small. But if the tumor size is kind of large, then you try to go for a Billroth 1. Now, in this case, in type 4, you have this type 4 ulcers are very close. They're very close to the gastroesophageal junction. You do a subtotal gastrectomy or a total gastrectomy, and you do a Roux-en-Y, right, with a total truncal vagotomy. That means you're cutting the vagus nerve right at the very root. Okay, so in this case, this is what the vagotomy is, and this is how you localize the tumor. Now, after you're done with this course or this lecture, please take the time to sort of go through this one time, because this is going to be asked in the oral interview during your theoretical questions. Like once you're done with the writing your essays, you might be asked something from this slide. Okay. So with that said, does anybody have any further questions? Okay. So we are going to now just go quickly over gastric cancer. So gastric cancer, essentially gastric cancer can be caused by gastric peptic ulcer, but most of the time it's because of smoking. It also has a lot of multifactorial causes, environmental causes, inheritance causes, right? So you have this thing here called the Laurent classification, which sort of divides the gastric cancer into two. You have intestinal cancer, intestinal causes, right? Or you have environmental causes like familial, poorly differentiated signet ring pathologies, right? And the only way to sort of differentiate whether this gastric cancer tumor itself was caused by an intestinal cause or a gastric cause is through the use of a biopsy. So you take a biopsy sample and then you look at it and see what kind of pathology you see. Now, that is not very important for you, because what is more important is the symptoms, right? Now, most of the patients with gastric cancer will come to you with non-specific abdominal pain, They'll have weight loss, which is a red black sign. They'll have dysphagia. And in very large tumors, they'll have gastric outlet obstruction, which is going to be one of the topics that we're going to discuss as well. But in gastric cancer, you have two types of classification, something called the Japanese classification, which is for early gastric cancer, and the Borman classification for type 2, right? The point here is that the Japanese have this early gastric cancer classification is important because you are going to be asked this on the exam if you have anything related to gastric cancer, right? In this case, the Japanese defined they looked at the shape of the ulcerative lesion that is found in early gastric cancer and divided it into basically three major types. So you have a pedunculated one in which it is coming out of the surface, right? And then you have type 2, which is of three types, right? In which you have an elevated type in which is not really coming out per se, but it is slightly elevated. One which is completely flat, it is in line with the rest of the gastric surface. And then type 3, which is a depressed one, right? And then you have type 3 excavated type in which you have a superficial excavation or a deeper excavation, right? The Borman classification is a bit simpler as well. This happens in advanced gastric cancer. Usually at this stage, you would probably have some kind of lymph node involvement as well, right? Now, you have type 1, which is, a polypoid. Type 2, fungating, it's spreading like a fungus, right? Type 3 is when it's ulcerated. So when you have an ulcer, you should do a biopsy if you think that this could be a gastric cancer, and gastric cancer usually occurs in the elderly. And you have type 4, which is infiltrative. So it looks like a lesion. It doesn't have any bleeding points or anything. It doesn't have very good margins. And in this case, it's serious late cancer, right? Now, in terms of the high yield, when you're doing a physical examination in a patient, you have to look for a periumbilical mass. If you feel a periumbilical mass, which is solid, firm, painless, that is called the Sister Mary Joseph nodule. And this Sister Mary Joseph nodule, right, indicates that there is a metastasis right down into the umbilical area. And it is a very advanced, almost incurable disease. It has a very poor prognosis. Maybe the patient will survive for another 6 months at the most, right? Now, what determines whether a cancer is serious or not are there two different factors, right? So the first is the depth of the tumor's invasion, and the second is whether there is lymph node involvement or not, right? Now here, for example, the most important thing that you should remember is that tumor markers are CEA, CA19-9, and CA125. If these three are not very clear for you, it is like you don't know whether it is completely elevated or is borderline. In that case, you use CA72-4 and beta-HCG, okay? And in terms of chemotherapy, you use epirubicin, cisplatin, and 5-fluorouracil. These are the types of chemotherapy that we use both before operating and after. In terms of surgical management, the good thing is that our principles of surgery are the same. You divide the location of the tumor the same way you would with a peptic ulcer, and you use the same surgical principles to sort of resect. So your resection margin plus your reconstruction, Billroth 1, Billroth 2, Billroth 1, 2, and Roux-en-Y or an extended Roux-en-Y, whatever. All of this is determined for gastric cancer in the same way that you would for peptic ulcer. Okay. And remember, and this is a large thing, whenever you mention for surgical management of gastric cancer, you mention these procedures and you mention lymph node clearance. Lymph node clearance is central to ensuring that you have good resectable margins and you have a chance either at palliating the patient or for curing the gastric. Okay. So with that said, we've completed gastric cancer. Does anybody have any more questions? Okay, if you have any questions, just type them in the chat. I'm going to go into two sort of not benign conditions, but sort of minor conditions. Oh no, there is a question here. Okay, is there? If you have a question, you can type. I'll wait. We probably have a question, so I'm just going to wait for a minute. Okay, so what is the questioner is asking here? What is the relationship between pernicious anemia, vitamin B12 deficiency, and gastric cancer? So it's a very complex relationship, unfortunately. So gastric cancer's morphology itself is not very well understood, right? We don't know what the entire genetic sequence is that causes the mutations that cause cancer. We know that certain occupational risks certain types of intestinal mutations, peptic ulcer disease, alcohol consumption, smoking, all of these things increase the risk, right? So when you ask about relationship between vitamin B12 deficiency and pernicious anemia, the problem is that there is no way to prove that there is a definite relationship. We know that there is a causal relationship. We know that there is no causal relationship, right? Because we have not been able to identify whether vitamin B12 deficiency definitely causes gastric cancer or not. It might increase your risk for it. We just don't know why. And that is the case for gastric cancer in general. We don't entirely know why certain diseases will cause gastric cancer. We know, for example, that peptic ulcer causes gastric cancer because even after you you resect a peptic ulcer, it is possible that they will have cancer simply because you can cause hypertrophy in that region, and that hypertrophy can cause gastric ulcerative mass, right? Then there are genetic predispositions. There are environmental factors. The fact is that unfortunately for gastric cancer, we don't know why it is caused in general. Now, one of the preventative techniques in patients, I'm sorry, the question just moved up. One of the preventative techniques in patients with atrophic cancer is taking folic acid. Look, folic acid is, okay. Folic acid does one of two things. Folic acid in general is given to patients because they have vitamin B deficiency, because the gastric tumor is it's interrupting the vitamin pathways, right? And in order to better tolerate chemotherapy, they're given folic acid therapy anyway. For atrophic gastric cancer is a very rare type of gastric cancer, exceptionally aggressive. And in those types of gastric cancer, by the time it comes to you to the department or to the clinic, it is most likely late stage, and it already probably has some kind of lymph node involvement, right? So it is debatable whether any kind of gastric dissection is going to be of any use. So we stick to just medical oncology, right? In that case, yes, you give them folic acid. And in terms of preventative, I'm not entirely sure like where you've read that, because I don't think it's preventative per se. It is useful for preventing complications through the chemotherapy. I'm not entirely sure where the preventative aspect of it comes into play, because with the atrophic gastric cancer, even the pathology is not very well understood. And I'm not sure, do you have like an organization that is recommending folic acid for preventing atrophic cancer? Because I'm not entirely sure. Because from what I remember, the European Society of Surgical Oncology does not have this in their recommendation. At least that's far as I know. So if you do have this, just do post it in the chat or message me privately, and I'll take a look at it. The second question is, if we get the gastric cancer topic, do we need to talk about gastric lymphoma or sarcoma? No. See, gastric lymphomas are different types of gastric cancer. They're called gastrointestinal stromal tumors. And it is not, if you have the time, you could write about it. But in general, when you're talking about gastric cancer, what they want to know is the two classification systems, the Japanese one and the Bohr one. If you have the time, yes, by all means, mention gastric lymphoid tumor, GALT, and GIST symptoms, right? Those are very important as well. But in terms of the exam, I don't think it's that important. Gastric sarcoma, very rare. So the thing is that it depends. It's up to you. If you have the time, write it. If you don't, let it be. So do we have any further questions? Okay, I'm going to wait for one more section, so that one more minute, so that you guys, if you have any questions, then we can go and discuss them. Okay, yeah, please do just send me the paper you've read, because it's very interesting. I'd like to read it as well. Okay, so we are going to now move ahead with something very simple, is gastric volvulus. Now, gastric volvulus is essentially when the stomach turns on itself, right? And it turns along two axes. One axis is called the organoaxial axis, when it just turns sort of on itself. The other one is mesenterioaxial, in which it twists on itself, right? So it doesn't flip per se, it just twists, okay? Now, for both of them, the management is, again, the same. You can either untangle it. If it's untangled, doesn't have any necrosis, you do something called a gastropexy, in which you just take the stomach and you just connect it to the rectus abdominis sheath and just stitch it up and just fix it in place. It usually happens in two groups of patients. One is those patients who have congenital anomalies, right? The suspensory ligaments of any one of these four could be loose, and that causes the stomach to move out of place and then flip on itself, right? And the diaphragmatic hernias can cause them as well. So, for example, the stomach will move past and up the diaphragmatic hernia, and maybe it comes down again, and in that it gets rotated, right? Now, in this topic, you have to remember Borchards' triad. So, Borchards' triad is epigastric pain, inability to vomit, right? And inability to pass an NG tube. Now, what happens here? What does that mean? Inability to vomit is that the patient wants to vomit, but nothing is coming out. It's called retching in English. The patient is in the retching, they have epigastric pain, it's sudden onset, aggressive, right? And when you try to insert an NG tube, you can't, right? And the only way to look at it from an imaging perspective is if you do a barium contrast study, and sometimes an endoscopy, but then the endoscopic tube is not going to go very far if it's a twisting. You know that there is a twist because you just see a twist of the stomach inside through the endoscopy. Most of the time, just a barium contrast study is more than enough, right? And remember that your management typically is just a gastropexy, right? Because patients with this kind of sudden twisting of the stomach, they come very quickly to the hospital because they have in sudden, very intense pain. They describe the pain as something they've never felt in their life before. They can barely stand up straight. They're usually just taken by the stretcher straight into the critical admissions unit simply because they are in so much pain that they can barely talk, right? They are conscious and they are aware. They have no sensory neural deficits per se, but they're just in an excessive amount of pain, right? So in that case, you just try to see if you can do a NG tube. You can't pass it through, then that means that this patient likely has a obstruction or a volvulus, and you just try to open it up and see what's going on. That's when you do something called a exploratory laparotomy. Exploratory laparotomy is when you cut open, you see, and then you fix whatever is wrong. It is a mainstay of certain types of most gastric emergencies and abdominal trauma. Okay. Now, with that said, we are going to go into gastric outlet obstruction, which is our final thing for stomach of the stomach section. And then we're going to go into colorectal, and then we'll only discuss 2 or 3 things because I don't want to waste all of your time. In gastric outlet obstruction, what happens is that this gastric outlet has been obstructed by something, right? You usually have a lot of different causes. You can have an ulcerative cause. So a peptic ulcer is right at the duodenal, at the pylorus or in the duodenum, right? And it is causing an obstruction, so nothing is passing through. Second is if you have a tumor mass. So tumor masses can be 2 types. You can have a tumor mass within the stomach, or you can have a periampullary tumor, right? Or a pancreatic tumor or a liver metastasis that is externally compressing this and causing gastric outlet obstruction, right? Or it can cause metastases, and the second metastatic tumor is present here and it is causing this obstruction, right? Now, sometimes pancreatitis can cause it, and it's a very interesting reason why, because what happens with pancreatitis is that sometimes the pancreas can swell up. If it swells up, it can push against the duodenum, and it can also cause an outlet obstruction, which can also cause some kind of backflow, because all of the periampullary region is sort of swelling up, and it is pushing against the duodenum itself and causes outlet obstruction, right? Now, in these patients, they have epigastric pain, nausea and vomiting, early satiety, which means that they eat only a little bit of food and they feel really full, right? And most of the time, gastric outlet obstruction is not like an acute cause. Most cases, it is chronic. That means that this patient has had vague abdominal symptoms for some time, and now suddenly they have had this pattern of symptoms for a few weeks, at least, if not a few months, right? And they have abdominal distension and weight loss. And weight loss is a red flag symptom for anything, including cancer. So anytime you think that a patient has complained about weight loss, just examine them for cancer. If you rule out cancer, then you can look at something else, right? Now, in weight loss, the reason why these patients have weight loss is because food is just not passing through, it's just getting clogged up here. They are going to have a lot of nutritional deficiencies as well. Maybe they complain that they are not feeling full after eating, or they feel like they've eaten food, but it's not doing anything for them. They may be cachexic, which means it's like they've severely lost a lot of weight, right? Your job, when you see that this patient may have gastric outlet obstruction, is to find out, number 1, the cause, right? Number 2, to try to fix it, right? Now, if it's a malign cause, you have distal gastric cancer, pancreatic adenocarcinoma, or gallbladder carcinoma, in that case, you may have to resect and do a Billroth 1 or a Billroth 2. In some cases, these are incurable. That means that it's a non-resectable disease because either the extent of cholangiocarcinoma, periampullary tumors, or the distal carcinoma is so vast that it has started affecting, by the time it reaches to the obstructive stage, there's already carcinomatous seeding all across the lesser curvature and all that. And at this point, it's no use trying to resect the patient because the patient will either not survive the surgery, will die of the complications from the surgery itself, right? Or will just not have a decent quality of life. So in that case, it's better to try to do non-operative management, which involves the insertion of a stent, right, via a guide wire that goes past the obstruction. So you just try to push past the obstruction and just go past, right? Laboratory tests, the point is that most laboratory tests may be normal unless you're looking for tumor biomarkers, which could be elevated. And in that case, it depends on whether you suspect there's a malignancy or not. You can have some electrolyte disturbances, but these electrolyte disturbances are most likely caused due to the vomiting because they are vomiting. They're just not going to keep down any food whatsoever. You have three different imaging modalities. The first is a CT scan, most helpful, right? Second is a barium swallow. So this is a barium swallow, what we're looking at here. And you can see in the barium swallow that this is the stomach and there is a stricture here, very narrow band. It is likely caused by some kind of fibrotic change, probably idiopathic, but it could be due to a prior abdominal surgery. And you can see that this is the pylorus as well, and this is also kind of distended, and you have maybe a secondary stricture here. I'm not sure. But in this case, you can see definitely that there is obstruction, right? In this case, it's more obvious because there is no pylorus at all. It's just stuck here, right? You can do an upper GI endoscopy, which will allow you to visualize it and see that it's a tumor. If it's a tumor, you can do an immediate biopsy and stage it and see what kind of tumor it is, whether it is a metastatic tumor from somewhere else, or it is a primary tumor. On the one hand, that you do surgical management, you have basically three different surgical management options. One is you can do a balloon stenting. So this is a metallic stent that is sort of bypassing the obstruction. In balloon stenting, what you do is you just insert a balloon and dilate the pylorus, right? So it becomes wider. And so all of this can pass through, whatever obstruction is there, right? The second one is when you do gastric resection, and you do this when the tumor size is so large and it is made out of like tumor material, or it is a metastatic tumor, or there's a lot of impaction and you can't really do a balloon dilatation. In that case, you do Billroth 1, Billroth 2, or you do a Roux-en-Y, right? You can also do a pyloroplasty, like I said, which is you just remove the pylorus and 3 centimeters before the pylorus, pyloric sphincter, and maybe 2 centimeters after, and you just cut it, and you sort of resect the duodenum to the gastrium and form continuation. So essentially, what you're doing is you're removing the pylorus plus the obstruction itself in most cases, right? You can do endoscopic gallstone removal. So one of the causes for gastric outlet obstruction, which is very rare, but it happens, is when a gallstone travels down the biliary tree and blocks the duodenum, or travels up, like sort of comes out through the biliary tree into the ampulla vata, goes to the duodenum, and sometimes it can go back and come up here somewhere and cause a massive obstruction. Very rare, but it can be done, and you use endoscopic retrieval using ERCP to just remove the stone, and your obstruction is out of the way. And of course, you can do stenting. Now, stenting is far more common here, right? You can use a stent to bypass it, and you sort of bypass the content so that you can give the patient some kind of fluid treatment as well. And in this stent as well, you can see that this is not a balloon dilation. This is just a stent. It has just opened up the pre-pyloric area and sort of passed the first part of the duodenum right into the lumen, so that food can just be passed through this. You remove the guide wire, by the way, just the stent remains, not the guide wire. The guide wire is removed out. So with that said, we are done with stomach cancer. I'm just going to stop sharing for a second here. Does anybody have any questions? Okay, so the thing is that about precancerous conditions other than gastric cancer, look, aside from gastric ulcers, there are neurinomas, we have gastrinomas, and those are all they're called neuroendocrine tumors. right? So neuroendocrine tumors are tumors that are not part of the they are not part and parcel of the stomach itself, right? But there are specific cells that have very specific functions. So, for example, they can release cholecystokinin, gastrin, argentaphin, things like that, right? And then neuroenoma in specific is a nerve tumor, sort of. I would say it's at the interface between the vagus nerve, where it connects and touches on the surface of the stomach itself. That's one type of neuronoma. You have other types of neuronoma as well. They're very rare, and in most cases, surgical resection is all you need. Now, in gastrinomas, your thing is that, like somebody just said, I'm not sure if it was you. I think it was you. Yes, serum gastrin levels will be high, right? The other thing in gastric tumors is that we have something called gastrointestinal stromal tumors, right? So gastrointestinal stromal tumors, the best way to describe them, aside with gastric lymphomas, is how do I say this without confusing everybody? Yeah. So it's called GALT, right? So GALT is a type of it's okay. Let's go into it in as much detail as possible. I mean, at this point, I don't think we should skip it in any way. So when you look at any kind of cancerous tumor, right? Let's go back to the very basics, right? You have, like, essentially when you look at an organ, you have the epithelium and you have the mesenchyme or the parenchyme, which makes the whole organ what it is, right? So epithelial tumors are like, they are like gastric cancer or the carcinoma types, right? But for example, let's begin with gastrointestinal stromal tumor. So the stromal tumor is basically a type of tumor that comes from the mesenchyme, right? And the difference is that the only way you'll be able to find out a difference is that they'll be positive for certain hormonal receptors called like CD117, BCL2, and CD34, right? Now, the point with stromal tumors is that they come from the stroma, right? So which means that they come from the muscularis layer, whereas carcinomas are going to come from the mucosal layer. Like, let's just remember it that way. The mucosa and submucosa layers cause carcinomas, right? And the stromal tumors come from the muscularis propria. So that's the interface essentially between the muscular layer on one side and the mucosa. They don't come from the mucosa themselves, right? Now, the point is that they can also come with like, the point is because they come from the muscularis, like they're just at the muscularis propria. It is not the lamina propria, by the way. Lamina propria is something else. It's an epithelial layer, right? The muscularis propria is essentially when you have two layers of the stomach, two muscular layers of the stomach. This essentially divides it into two parts, right? So GIST tumor, the gastrointestinal stromal tumor, it is a type of precancerous tumor, or essentially it's not non-cancerous, you would say, but the type, it's what they are asking for when they are talking about precancerous condition. This kind of tumor lesion is in between two muscular layers. And because the nerves come from outside and go into the submucosal layer while passing through the muscles, you can have some kind of gangliomas as well. So those gangliomas that you find, they are a direct response to the presence of a tumor mass in close proximity to them. And those are not tumors themselves. That's just a ganglioma. It's more or less a benign precancerous condition. It can become one under very rare circumstances, but it is not in itself a tumor, right? Now, the point is that this lamina propria tumors, right, the GIST tumors themselves, they cause bleeding, and they cause something called dysplasia, right? That means the entire area has a lot of different types of cells, and they're penetrating from the submucosal layer, right? Like from the submuscularis layer right into the submucosal layer. And in this this transition, it makes it very difficult for us to target them with radiotherapy. We can only target them with chemotherapy, and the only real thing that we can do is to do a gastric resection, which is why it is important for you to understand gastric resection. Now, when we look at fibromas and fibroids, right? Like fibroids and fibromas are benign. They occur because of a lot of different causes. One of the most common causes would be if a woman has uterine fibroids, for some reason she could also have gastric fibroids. Not in all cases, but there is some link there. It's not a causal correlative thing, but it has just been observed. The other thing about fibroids is that it occurs because of chronic inflammation. So when a person is drinking too much, they take a lot of alcohol, they take a lot of caustic material. They have chronic gastritis, for example. In some cases, they could have a fibrotic change, and that can cause a fibroma, right? And even with the fibroma, you can't just excise the fibroma. You can do like a wedge resection. If it's really small, you most of the time leave it. By the time you see it in the clinic or something, or the patient has symptoms, it's largely very large. So in that case, you have to do a resection. So you go back to the main treatment, which is basically Billroth 1, Billroth 2, Roux-en-Y, right? Now, there is a rare type of like gastric. So there is gastric lymphoma, right? So if gastric lymphoma is a type of lymphoma, we also call this marginal cell lymphoma. It's also called MORG. But the more it's not entirely a gastrointestinal tumor for in the strictest sense of the word. It's because the B cells that are part of the immune system have caused a tumorous mass in the stomach, right? So it is basically a oncohematological disease. The only point that it becomes a surgical problem is that if this lymphoma has, like, there are multiple smaller lymphomas and they cause outlet obstruction, or they cause bleeding, or they cause a perforation, which in of themselves are very rare, right? That's when they become surgical problems. And most of the time, it's not your issue. If it's a lymphoma, remember, lymphomas or anything with the lymph thing always needs a hematologist and an oncologist, like a hematologist, to deal with it. And mostly for them, it's very difficult for us to do any meaningful resection. Resections are only done for metastatic cases. In those things, if there's a metastasis somewhere else and causing symptoms, then you can resect and remove it. But those are aspects of palliative surgery, which are not palliative surgery, which are they are their own ball game of when you choose to do palliation versus curative intent, right? Let me see if there's anything else here. See, look, for normally for lymphomas, right? If you have to write about precancerous regions, like try to write about lymphomas. But in lymphoma, remember, the most common thing is a type of atrophic gastritis is the histological change that you'll see. And the patient will have symptoms of dyspepsia, abdominal pain, and maybe some kind of upper GI bleeding. That's it. For neurinomas, it's usually dyspepsia, pain, yes, and maybe there is gastric outlet obstruction because of gastric or duodenal ileus. That's it. But that's the main overview of it. If it is possible, maybe by the end of the week, I'll try to make a small presentation, which I'll send it all in the group or on your emails or something, and you should receive it there. So I hope that was clear enough. Is there any further questions? Yeah, you're welcome. Anytime. So do you have any other questions? Anybody else? Okay. So what we're going to do now is very quickly, we're going to go through colorectal surgery because I've taken a lot of your time, right? But there is no other way around it because colorectal surgery is very, very important for the exam. And I want everybody to be able to master colorectal surgery to the best of their abilities, right? So we are just going to go through colorectal disease. Today, we'll just go through the basic parts, the most important ones. If nothing else, right before your exam, at least study what is there on the upcoming presentation. Okay, so I think this should be it. Okay, yeah. So this is colorectal surgery. Now, colorectal surgery, remember, deals with everything that starts from the colon, right? The cecum, ascending colon, transverse colon, descending colon, sigmoid, rectum, anal canal, right? And it includes both benign conditions as well as malignant conditions. So you'll be doing colorectal cancer as well, plus non-cancerous conditions like ischemic colitis, ulcerative colitis, Crohn's disease, IBD, IBS, hemorrhoids, anal fissures, and any problems with the rectum, right? Now, again, today we are going to look at some of the operative procedures as well, because these operative procedures are not just used for one specific type of surgery. So, for example, like we discussed, Billroth 1, Billroth 2, Roux-en-Y, you could use them for a wide variety of conditions. They're your toolbox, essentially, right? Here also, even in colorectal surgery, we have a certain toolbox. We'll go through that. And those toolboxes are used for different types of conditions, right? So let's go into the colorectal surgery thing as quickly as possible. The first thing is that I want to just I want all of you to look at the anal canal first. So the anal canal is the lowest most part of the colorectal system, right? And in the anal canal, the most important thing is something called the pectinate line. So this pectinate line divides the anal canal into two areas. There is a superior area, which is the superior 2/3. It's called the superior portion of the anal canal. This thing's nerve supply is very different from the external or the lower inferior portion or the infrapectinate portion, right? And why is this important? This is important because the superior part of the anal canal, like this area, is not sensitive to pain per se, right? Pain, pressure, sensation, warmth, all of these come from the separate nerve supply, right? Which are branches of the pudendal nerve, and they are affected, they are more likely to be in the inferior pectinate region. So if a patient comes to you with pain upon bleeding, right? Pain upon defecation, pain in general, pruritus, it's because the involvement here is from the infrapectinate line, right? So something in the anal verge or the anal canal in the most inferior-most position is being affected, right? Second, when you look at the anal verge is just the outermost part of the anus. It is very different from the pectinate line. The pectinate line is deep inside. The pectinate line is more or less a line where the histology changes a bit, right? Now, the histology bit is not that important right now because we're not doing rectal cancer. We'll do rectal cancer in the next one. Today, we're going to just discuss benign conditions like hemorrhoids and all that, right? But remember that, just remember the pectinate line, right? And remember the suprapectinate anal canal and the infrapectinate anal canal, right? The rest of it, just read through it once is enough, right? And just remember that the nerve supply is different, and so is the blood supply. And that is important because, like I said before, earlier, and even in the previous lecture, the blood supply to an area and the nerve supply can sometimes determine the kind of operative procedure you're doing. Okay. So let's go on to the next slide. Anorectal disease. Now, can everybody see the slide? Are the font sizes too small? Okay, so the font sizes are a bit too small. So what I'm going to do is, in general, just take a look at what I'm going to do is I'm going to zoom in. Now, anorectal diseases, basically, we have hemorrhoids, we have fistulas, anal fissures, and rectal prolapse, right? Now, the point is that hemorrhoids, in all of these conditions, you need to know the classification system for your exam. Whatever you do, please write the classification system. If you can't remember the surgical management, write the classification system, right? Now, for hemorrhoids, we just define the hemorrhoids into two types, right? We have a grade 1 hemorrhoid or a grade 2 hemorrhoid or internal and external hemorrhoid, right? Now, usually, we use the dentate line or the pectinate line to sort of delineate where the hemorrhoid is. So internal hemorrhoids are of two types. We have grade 1, grade 2, and grade 3, right? Grade 4 are borderline, grade 5 or external hemorrhoids are those that are outside of the anal verge itself. Now, when you look at a hemorrhoid, right, if it's entirely internal and doesn't protrude out, right, it's a grade 1 hemorrhoid. Grade 2 hemorrhoids are those that they sort of come out of the anal canal, right, upon defecation, but they reduce spontaneously. That means they go back inside, right? Grade 3 are those that go outside of the anal canal, right? But the patient needs to push them back inside, right? And grade 4 are those that are completely, they are not going to, it comes out and it just stays out. And those are the ones that mostly cause the symptom. So if a patient comes to you with painless bleeding, remember that painless bleeding and this feeling of something or a mass or something in the rectum or in the anus is most likely going to be a type 4 one because it is not reducing anything, right? And remember that grade 1 tumors, the grade 1 hemorrhoids can always progress to grade 4 hemorrhoid simply because of repeated straining. And most of the time they transform from grade 1 to grade 4 simply because there's some kind of internal thrombosis. Now, internal thrombosis takes place because the hemorrhoids themselves hemorrhoids are a venous plexus essentially, right? They form sort of perfusion beds for the anorectal region, right? Or rather the anal canal itself, especially around the internal sphincter. Now, the point is that because it's a cushion that already has the venous plexuses, they can sometimes sort of get stuck with blood. They fill up with blood, they congest, then they swell up, and then you have a thrombosis, and then that thrombosis causes pain. And it causes pain especially when it crosses the pectinate line. Because once it crosses the pectinate line, this is where the pain fibers are here. So if you can see here, grade 2, grade 3 and grade 4 are the ones that sort of cause you the pain. right? Now, when you look at fissures, let's not go to fissures, so let's go to fistulas. So a fistula is a type of connection of epithelium or between two epithelial surfaces, right? So the first epithelial surface is that normally with a fistula, what happens is that this is the perianal region. This is the skin essentially. This is the internal anal canal. Like this is the hemorrhoidal plexus, right? And this is the internal anal sphincter. This is the external anal sphincter, right? Now, in fistulas, you have 4 different types of fistulas. You have fistula Parks type 1, which is intersphincteric. And what happens is that the internal or the external opening is here, and it forms a canal and a communication between something and goes inside and opens up in the internal anal canal. So there are 2 connection points here, right? There's an entry point on the skin and an exit point in the internal anal canal, right? It is intersphincteric because it is passing through the 2 sphincters, right? Second is that it could be suprasphincteric, which is a Parks type 3, in which it goes up, goes past the past the external sphincter's topmost part, and still comes out inside. So remember, the rule with the fistula is that it has to have an opening which is inside the anal canal, right? It has an internal opening and an external opening. The external opening is always on the skin, and the external opening is always inside the internal anal canal, right? Now, if, for example, you may have a question, what happens if you have 2 internal openings? Usually, for the rare case that you have an internal opening that is inside and it's a second opening is inside, is no longer a fistula, it's most likely going to become an abscess. And because it has made this damage, part of the sphincter is going to come. This kind of thing is only seen in repetitive trauma, right? Or not even repetitive trauma, it's very rare. It's usually when someone has deliberately caused anal trauma, right? And that is usually because of sexual assault of some kind, right? Otherwise, from a physiological perspective or a pathological perspective, you just have this kind of classification of the sphincters, of the fistula, right? Now, the treatment in general also depends on this as well, which we'll discuss in the next slide. But here, I just want you all to sort of focus on this thing here. Yes, he did talk about mixed and combined hemorrhoids. So mixed and combined hemorrhoids are this. Normally, you don't have, when we talk about grade 2, grade 3, grade 4 hemorrhoids, right? The point is that by the time a patient has a grade 4 hemorrhoid, they also probably have a grade 1 hemorrhoid. You never have only one hemorrhoidal mass, right? The point is that the reason, what happens is that you don't usually have just one hemorrhoidal mass. You'll have multiple of them. And in most cases, you can have a grade 2, grade 3, or a grade 3, grade 4. So they are usually in this kind of combination, right? From the statistical studies, this is what we see. Now, your treatment option for hemorrhoids is not going to change. You'll usually you classify the treatment based on which is the most serious one, in which case it'll be grade 4 always, right? In grade 4 hemorrhoids, you have to try to remove the hemorrhoid because it's going to be constantly painful, prone to infection, and it can progress from a hemorrhoid to an abscess, which is a serious problem, especially in the anal canal, because all the feces are coming out here. And when they come out from the anal canal, this is a lot of bacterial colonization and can cause septic shock. And remember that these hemorrhoids are because inside the hemorrhoidal sac, so to speak, are venous plexuses. They have some communication with the rest of the body's blood supply. And if there's any kind of break here and there's infection, that infection can spread and cause septic shock. So that is the one concern that you need to know. Thank you for pointing it out. Second, what are anal fissures? So anal fissures are just a mucocutaneous defect. So while a fistula is also a mucocutaneous defect, it's a defect that has a clear path, right? It has an entry and it has an external outward tract and an internal opening, right? It has 2 openings. Whereas a fissure is basically it doesn't have an internal opening per se. It just looks like a long crack sort of. While this looks like a tunnel, a fistula is a tunnel essentially. A fissure is a crack, right? So it won't be this deep and won't go inside. It'll be in a straight line. Mostly maybe it goes up till the dentate line at the most, right? Rectal prolapse. Rectal prolapses usually occur because this levator ani muscle is not strong, right? And the entire rectal body sort of collapses through. And you can have 3 types. You can have complete, partial, or occult. Now in occult, what happens is that the rectal canal prolapses inside and causes intersusception, which is basically a telescopic formation. A telescopic formation essentially when you have part of the anal canal is sort of fallen, a part of the rectum has fallen into the anal canal like this, right? But it hasn't protruded out of the anus. It's still there, right? In partial rectal prolapse, you have the prolapse of the mucosa only. So that means only this mucosa, this white layer here that you see, only that has prolapsed, right? In complete rectal prolapse is the involvement of the bowel wall itself. So the entire bowel wall, this white line, all of it has prolapsed through the anal canal. That is what rectal prolapses are. So let's go on to the next one. What surgeries we do. Now, because we've been here for more than an hour and I don't want to strain your attention, we'll pick this up next week, right? But remember that you have rubber bands. For internal hemorrhoids, especially for combined hemorrhoids, you can do rubber band. Now, if you have grade 1, grade 2 hemorrhoids, which are not really that painful, not causing obstruction, not really symptomatic generally, right? You give the patient a sitz bath, right? Or you give them a vasodilator like nitroglycerin, right? It's topical nitroglycerin cream. It allows the vessels to sort of expand and blood flow can continue and the hemorrhoid is reduced on its own. But this is only for grade 1 types, right? The moment you have a mixed combined type or a grade 3 or grade 4 one, you have to go for surgical management, and which you have 3 types. You have this conventional hemorrhoidectomy, in which you just you put the patient in a jackknife position. Jackknife position is when the patient is bent over, right? They're lying down and bent over, and you can expose their anus and everything. And then you go inside and you just use a dilator retractor or an anal retractor. It sort of opens up the anal canal. You go inside, cut out the hemorrhoid, suture it up, and close it shut, right? That's a complete conventional hemorrhoidectomy. However, we try to do a hemorrhoidal artery ligation, in which you just go deep with this instrument here, this is a ligator, and this just cuts out the supplying artery or vein here and just lets it dry out, so to speak. And the third one is a stapled one, in which you basically staple it shut. You have a very small stapler, staples, cuts, removes, right? And while it is stapling, much like any GI stapler, it just crushes and it staples the skin, or it staples the mucosa together, and it heals on its own, right? Of course, you have a band ligation as well, but the point with band ligation is that it is not always used anymore. It is better to use a hemorrhoidal artery ligation. Rubber band dilation is more conservative treatment because you are going to still have symptoms eventually, and the patient is going to come back for surgical management anyways, right? In terms of fistulas, the most important thing is that you do something called a fistulotomy plus cetons. This is the one that is used here and in general, because just a conventional fistulotomy is good only for very small fistula. So you just cut it open, let it heal on its own slowly. It'll heal through secondary intention. So it is allowed to just heal on its own. You don't approximate anything, you just leave it open, right? But in cetons, what happens is that you use this for very large fistula tracts, right? And what a ceton is just a rubber band. You pass the rubber band through the fistula itself and just keep tightening, right? And as you keep tightening it, what it does is that it sort of crushes whatever's inside that, inside the mass of muscle tissue or myocutaneous tissue that is within the rubber band. And as you keep tightening it, it strangulates it, and slowly that thing becomes smaller and it dies off. And this internal surface comes out essentially. That's rubber band dilation, right? And with cetons, it's called graded treatment. So grading treatment is when, or staged procedures in which you take some time over multiple visits. Usually it takes 4 to 8 weeks. By the end of the 8th week, you'll have a healed fistula tract. There'll be some scar tissue, but that scar tissue is not really going to do much because it's going to be on the outer part of the anus. Now, for anal fissures, basically what you can do is, most of the time you do a chemical sphincterotomy, in which you just insert nitroglycerin. And what nitroglycerin does is that it causes the wound perfusion to be better, because the fissure can heal just by increased perfusion, because that way you have more immunological elements to come and sort of heal that area, right? But the issue here is that conventionally you use something called sphincter dilation. The sphincter dilation is when you insert a dilator and you just keep opening and you dilate the anal region completely. You hold it there for a couple of minutes, So what happens is that the wound bed gets into much more closer proximity with the vascular bed, and that way it forcibly increases the perfusion, which causes healing. But the problem with this is that when you're trying to expand the anal sphincter, a lot of patients will lose a lot of the control of the sphincter. So you can have fecal incontinence with these patients, right? So nowadays they have something called a lateral sphincterotomy, which is called Notar's procedure. This is the Notar's procedure, in which you go in between the internal, like you go inside the internal sphincter and you just cut it open. And that the internal sphincter sort of is a double layer, and it'll just open up and relax, allow more wound perfusion and reduce the amount of pressure inside the anal canal. And this will allow the fistula to heal, the fissure to heal. The final thing here is that sometimes for fistulas themselves, we use an advancement flap, which is when you take a bit of like, this is what the advancement flaps generally look like. You make a cut around the anorectal canal, right? Take part of the mucosa and everything, and you just advance it up further into the anal canal and just stitch it. That's just an advancement flap, and this covers your fistula's defect. And essentially, it's trying to cover the internal opening, which is inside the internal anal canal. Okay. Now, for rectal prolapse, the mainstay of treatment, right, is through something called the Altemeyer's procedure, in which all of this area that has prolapsed out is completely excised, right? And then you stitch it outside and you reinsert this into the anal canal. So you basically, whatever rectal part has been prolapsed out, you cut it out, and you take a bit of the colon, and you remaining whatever bud is left, right? In here you see this bud that is left. You put this back inside, and you connect it with the colon. So that's a collector. That's a coloanal anastomosis. That's what you create here, and that's called Altemeyer's procedure. Altemeyer's procedure is very important. This is a named one. You need to remember. Okay. So with that said, we are going to just, this is very important. So just as the last note, we are going to cover this section onwards with all the tumors of the colorectal cancer and all specific treatments. But before you come for tomorrow, for the next lecture, which is next week on Monday, please go through this, right? If nothing else throughout colorectal surgery, please try to know this. Like if there's a tumor in the cecum, it's going to be a right hemicolectomy, right? This tumor localization or surgery based on tumor location is very, very important, not just right now for your 5th year exam, for your 6th year exam. It's also important when you apply for jobs in a surgical department in the UK. It is one of the foundational competencies, so that you know what kind of operation has been done, right, on a certain patient. You may be asked sometimes to remove a colectomy bag or clean a colostomy bag. Some of your general practice patients may come after these surgeries, right? So it is very, very important that you study this topic. And the next time I'm going to go into this more in greater detail, right? So I'm going to just give you guys some time to ask some